Hello students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we are going to discuss about the surgical management of prolapse part 2. Right, so in the previous module, we dealt about the surgical management of prolapse in reproductive age group female. And I discussed about the important algorithm which you need to learn about the management of prolapse, right? I told you that with respect to uterocervical prolapse, the age and the parity of the female needs to be taken into consideration in order to decide the treatment plan. Whereas for the treatment of vaginal prolapse, the age and the parity of the female is not important, right? So the age and the parity of the female is important with respect to uterocervical prolapse, but for vaginal prolapse, the age and the parity of the female is not required in order to decide the treatment plan. So in this module, we are going to deal about the management of vaginal prolapse in all age group females, as well as in part 2, we're going to be deal about the management of uterocervical prolapse in menopausal age group female. Is that clear? Yes. So this is what we are going to discuss in this module. So to begin with, what is vaginal prolapse? So in a short gist, vaginal prolapse is when the important supports of the vagina are loosening its strength and its integrity, right? Then the vagina is going to become loose. So the structures which are immediately near to the vaginal wall are going to herniate out through the weakened vaginal wall. Is that clear? Yes. So with respect to vagina, we know that there are two important walls, the anterior vaginal wall and the posterior vaginal wall. So the anterior vaginal wall can be divided into upper two-third portion and the lower one-third portion. Similarly, the posterior vaginal wall can be divided into the upper one-third, the middle one-third and the lower one-third portion. So let's say, for example, the structures which are immediately near to the upper two-third portion of the anterior vaginal wall is the urinary bladder. Is that clear, everyone? Right? The structure which is immediately near to the upper two-third portion of the anterior vaginal wall is the urinary bladder. So what is going to happen is this urinary bladder is going to herniate out through this loose anterior two-third portion of the vaginal wall, right? And it is going to herniate out. Similarly, the structure which is immediately near to the lower one-third portion of the anterior vaginal wall is the urethra, right? So this is the urethra. So this urethra is going to herniate out through this weakened lower one-third portion of the anterior vaginal wall. So if urinary bladder is going to herniate through the upper two-third portion of the anterior vaginal wall, it is called as cystocele. And if urethra is going to herniate through the weakened lower one-third portion of the anterior vaginal wall, it is called as urethrocoele. Similarly, in the upper one-third portion of the posterior vaginal wall, the intestines are going to herniate out. It is called as enterocoele. And the middle one-third portion, the rectum is going to herniate out through this weakened middle one-third portion of the posterior vaginal wall. And the lower one-third portion of the posterior vaginal wall, the perineal supports are going to become laxed and weak, which is called as laxed perineal support. Is that clear? So with respect to anterior vaginal wall, we have cystocele and urethrocoele. With respect to posterior vaginal wall, we have enterocoele, rectocoele and laxed perineal support. So this is all which we have discussed in the previous module. So now we gave only a small gist about the vaginal prolapse. If you haven't watched the vaginal prolapse module, please go back, watch that module and then come here so that it will be very easy for you to understand. Is that clear? Yes. So now discussing about the management of vaginal prolapse. So anterior vaginal wall prolapse is all about the cystocele and the urethrocoele. So now how are you going to manage the cystocele and urethrocoele? See, the major problem with the vaginal prolapse is because the vagina has become weakened. Because the supporting structures which are keeping the vagina in its normal anatomical position has lost its integrity and it has become weakened due to various prevailing risk factors. So because of that reason, the vagina has lost its support and therefore the structures which are immediately near to the vagina is herniating out through this weakened vagina. So the treatment which you have to do here is to strengthen the vaginal wall, which is called as anterior colporrhaphy. Why it is called as anterior? Because in case of anterior vaginal wall prolapse, you have to repair only the anterior vaginal wall. So therefore anterior. And what do you mean by colporrhaphy? So the word colpo stands for vagina and the word rhaphy stands for repair. So it is ideally repair of the anterior wall of the vagina, which is called as anterior colporrhaphy, which is the management of anterior vaginal wall prolapse, that is cystocele or urethrocele. Is that clear? So therefore anterior colporrhaphy is also termed as anterior vaginal wall repair. And this anterior vaginal wall repair or anterior colporrhaphy is a non-invasive procedure, and at the same time it is a reconstructive surgery. Why it is a reconstructive surgery? Because you are going to strengthen the vaginal wall, right? You're going to put sutures and you're going to make the anterior vaginal wall strengthen. So since you're going to reconstruct the integrity and the strength of the anterior vaginal wall, it is therefore a reconstructive surgery. So therefore it is a non-invasive as well as it is a reconstructive surgery. So what are you going to do here is that between the bladder and the vagina, right? So here is the anterior vaginal wall, and immediately near to the anterior vaginal wall is the urinary bladder and the urethra. So between the bladder and the vagina, whatever tissues are present, that you are going to just suture it. So repair the anterior vaginal wall tissue that has become weak. So between the bladder and the vagina, whatever support is weak, you are going to suture those supports and make it very strong, and you are going to implement its integrity again. So the major role of anterior colporrhaphy is to reinforce the strength to the muscular and the tissue supports. Is that clear? Yes. Okay, so now coming to the B. So the next part is all about the posterior vaginal wall prolapse. So with respect to anterior vaginal wall prolapse, we discuss about the cystocele and urethrocele. With respect to the posterior vaginal wall prolapse, we have three things. And what are those? Enterocele, rectocele and lax perineum, like we saw here, right? So the portion which is immediately near to the upper one-third portion of the posterior vaginal wall is the intestines. So intestines can herniate to the upper one-third portion of the posterior vaginal wall, and the portion or the structure which is immediately near to the middle one-third portion of the posterior vaginal wall is the rectum. So therefore the rectum can herniate through this weakened middle one-third portion of the posterior vaginal wall, right? So similarly, the lower one-third portion of the posterior vaginal wall, the perineal supports can become weakened and herniated, which is called as laxed perineum. Clear? Yes. So as you can see here in this image, so this is the anterior vaginal wall, this is the posterior vaginal wall. The structure which is immediately anterior to the anterior vaginal wall is the urinary bladder and the urethra. And here you can see that the bladder is herniating out through the anterior vaginal wall, upper two-third portion. So that is called as cystocele. And here, what you can see here, what you are able to see here is the intestines are herniating out, right? The intestines are herniating out through the posterior vaginal wall. Which portion of the posterior vaginal wall? Upper one-third portion of the posterior vaginal wall, the intestines are herniating out. So therefore, this is called as enterocele. The word cele stands for herniation. Entero stands for intestines. So intestines are getting herniated. Similarly, cysto stands for the urinary bladder. Cele stands for herniation. So the urinary bladder is getting herniated out. Right? Clear. So with respect to posterior vaginal wall prolapse, the management is that you have to repair the posterior vaginal wall, be it either enterocele, rectocele or lax perineum. The management is going to remain the same, that is posterior colporrhaphy. Now you may have a doubt that why have you written posterior colpoperineorrhaphy? It is because we told that the lower one-third portion of the posterior vaginal wall, if it is going to herniate out, it is called as laxed perineal support. So therefore you have to repair the perineum as well. So here you repair the perineum along with the posterior vaginal wall, which is called as posterior colpoperineorrhaphy or posterior vaginal wall repair. Similar to anterior colporrhaphy, posterior colpoperineorrhaphy is a non-invasive procedure. It is a reconstructive procedure where between the vagina and the structure which is immediately posterior to the posterior vaginal wall, that is the empty pouch, which is the cul-de-sac, and the rectum and the lax perineal support, right? The perineal supports, the important perineal supports, as well as the rectum, as well as the empty sac, which is the cul-de-sac or the recto-uterine pouch, right? So this pouch and the perineal supports as well as the rectum, whatever tissues and important supports are present between the vagina and the rectum, all these have to be repaired. How are you going to repair it? You are going to reinforce the strength by suturing it. So when you're going to suture all the structure together, it is going to be stiffened and it will prevent the posterior vaginal wall prolapse. So the basic is that you're going to repair the posterior vaginal tissue that has become weak. Is that clear? Yes. Now, moving on to uterocervical prolapse. So with respect to vaginal prolapse, there is only two management, which is anterior colporrhaphy, posterior colpoperineorrhaphy. Anterior colporrhaphy is for anterior vaginal prolapse. Posterior colpoperineorrhaphy is for posterior vaginal wall prolapse. So now we are going to discuss about the uterocervical prolapse management in menopausal females. So what are the managements which are available to you for the management of uterocervical prolapse in menopausal female? So if you're going to ask me the question, what is the management of uterocervical prolapse in menopausal female, I am going to say only one thing, and that is hysterectomy. What is hysterectomy? Hysterectomy is removal of the uterus and the cervix, right? Hysterectomy is removal of the uterus and the cervix. Why? Because it's that in menopausal female there is no use with the uterus and the cervix. So if prolapse is going to happen, if uterocervical prolapse is going to happen in a menopausal female, it is better that you are going to remove the uterus and the cervix in that female, so that the symptomatic relief will be present for that female. And at the same time, if you're just going to reduce the prolapse, sooner or later it is going to recur very soon, right? So in order to prevent all that, the best management to be done for uterocervical prolapse in menopausal female is hysterectomy is the best option for menopausal females with uterocervical prolapse, right? So let me show you here, right? Hysterectomy is the preferred option. And which is the hysterectomy which has to be done for a female with uterocervical prolapse? It is the vaginal hysterectomy, where you're just going to remove the uterus and the cervix. Is that clear? You remove the uterus and the cervix, the remaining portion of the vagina is going to be there, right? Like you can see here. Let's say, for example, this is the uterus and this is the cervix. Now you're going to remove the uterus and the cervix. Now only the vaginal portion will be present. And you're going to just suture the apical portion of the vagina and let it as it is, right? So only the portion of the vagina is going to be remain, and which is called as vaginal stump, right? The uterus and the cervix has been removed. Only the portion of vagina is left behind and the apical portion of the vagina is sutured. And this portion of vagina is called as the vaginal stump. Okay. So the best management of uterocervical prolapse in menopausal female is hysterectomy. The preferred hysterectomy is the vaginal hysterectomy, and in vaginal hysterectomy you're going to remove the uterus and the cervix, and the remaining portion of the vagina, the apical portion of the vagina, is going to be sutured and it is going to be left as it is, and the portion of the vagina which is going to remain inside is called as the vaginal stump. Okay, so now what is the other management available? So if hysterectomy cannot be done in a patient with uterocervical prolapse in a menopausal female, the next option which can be considered is Leiford's colpoclysis. What is Leiford's colpoclysis? Leiford's colpoclysis is basically a minimal invasive procedure. And at the same time, it is not just minimally invasive, but then it is an obliterative procedure. You're going to obliterate something. But what are you going to obliterate? You are going to obliterate the path of the vagina. Let's say, for example, this is the vagina. In the vagina, a rectangular portion of the vagina is going to be removed. And as soon as the rectangular portion of the vagina is going to be removed, the vagina is going to be sutured. So therefore, there is no outlet path present in the vagina. So when there is no vaginal orifice, then therefore the patient is going to experience decrease in sexual desire is going to be present. Because why? Because the patient cannot have any act of coitus after the vagina, the path of the vagina has been obliterated, right? See, Leiford's colpoclysis is when the pathway of the vagina is obliterated by removal of a rectangular piece of the vagina, and the remaining portion is going to be sutured off. So therefore, there is no vaginal outlet here. So when the vaginal outlet is not present, then therefore this female cannot indeed in any act of coitus in future. So therefore, in females who are desiring future conception and in females who are desiring coitus, this procedure cannot be done. So therefore, this procedure can be done in a menopausal female who doesn't have any further sexual desire, right? So this procedure can be done in that female. And apart from that, Leiford's colpoclysis can be considered as a treatment option in elderly postmenopausal female with comorbidities present. What are the comorbidities? The most common comorbidities such as diabetes, hypertension, coronary artery disease, etc. Right? So elderly female, postmenopausal female with comorbidities. In such female, it is not safe. It is not at all safe to just put anesthesia for a longer period of time and operate her on table. So therefore, instead of vaginal hysterectomy, you can consider this Leiford's colpoclysis, where the basic of this procedure is you're going to obliterate the path of the vagina. So you're going to remove the rectangular portion of vagina and the remaining portion is going to be sutured. So therefore, there is no vaginal outlet. Therefore, this procedure cannot be done in adolescent and in reproductive age group female. Why? Because is that if you're going to close the vagina outlet, then therefore if a reproductive age group female is going to be undergoing this procedure, then therefore in the next month, if the female is going to menstruate, the menstrual blood will never be able to come out because the vaginal tissue has been removed and the remaining portion has been sutured. When there is no outlet, how can the menstrual blood come out? Right? One point. The second most important point is that when there is no vaginal outlet, then the patient cannot involve in any act of coitus. So therefore, this procedure, Leiford's colpoclysis, can only be done in elderly postmenopausal female with comorbidities as well as in females with decrease in sexual desire. Right? So in that group of female, Leiford's colpoclysis can be done. Clear? Yes. Now what are you seeing here? The vaginal hysterectomy. I told you that in vaginal hysterectomy, what you are going to do is this is the uterus, right? This is the uterus and this is the cervix. In vaginal hysterectomy, you are going to remove the uterus and the cervix. The uterus and the cervix is removed. So the remaining portion, that is the vagina, is going to be present here. Now what I'm going to do here is that I'm not going to leave the vagina as it is. I'm going to suture this apical portion of the vagina and left as it is inside. So this portion of the vagina which has been sutured is called as the vaginal stump or vaginal vault. But the complication here is that if uterus and cervix can prolapse, then similarly vagina can also prolapse in that same female. Why? Because some predisposing factors were present in that female which led to the uterocervical prolapse. So if those risk factors can lead to uterocervical prolapse, then why don't these risk factors can also lead to this vaginal prolapse, right? It is because once the uterus and cervix is removed, the vaginal vault portion is going to remain. But after hysterectomy, that is post-hysterectomy, there are chances for this vaginal stump to get prolapsed. So how are you going to prevent this vaginal stump prolapse is by doing some prophylactic procedures which is called as uterosacral suspension. What is uterosacral suspension? So uterosacral suspension is when sutures are just made between the uterosacral ligament and the apex of the vagina. So as you can see here, right, this is the apex of the vagina and this portion is the uterosacral ligament. So between the uterosacral ligament and the apex of the vagina, sutures are tied. So this uterosacral ligament is going to suspend the vault or the apical portion of the vagina, and this uterosacral suspension is going to prevent the vault prolapse in future, right? So prophylactically, in all females who are undergoing hysterectomy for the management of uterocervical prolapse, in that female, you can do uterosacral suspension in order to prevent post-hysterectomy vault prolapse, right? Post-hysterectomy vault prolapse. So this question has been asked as one of the Mackler solve. If you haven't attended any Mackler solve, you go to the post section and attend the Mackler solve, right? I asked you a question that post-hysterectomy vault prolapse, the prophylactic procedures which can be done is uterosacral suspension, where the uterosacral ligament is going to suspend the vault of the vagina and it is going to hold it in its normal anatomical position and prevent the post-hysterectomy vault prolapse. Clear? Yes. But then you also need to consider that uterosacral suspension can be used to prevent the vault prolapse, and at the same time, if vault prolapse is going to happen after hysterectomy, this uterosacral suspension can also be used to treat the vault prolapse as well. and this uterosacral suspension can be done through abdominal route or through the vaginal route. This procedure can be done. Clear? Yes. Now, so one such important procedure was uterosacral suspension. Now, how are you going to manage this wall prolapse? If wall prolapse is going to happen, is uterosacral suspension the only option available to us to treat this wall prolapse? No. There are other such procedures as well, and those are the sacrocolpopexy. Sacrocolpopexy. What is sacro? Sacro means sacrum. Colpo means vagina. Pexy means you are going to suspend the vault of the vagina by just suspending it to the sacrum, right? As you can see here, in sacrocolpopexy, a mesh is needed, right? In uterosacral suspension, you are just suturing it. But in sacrocolpopexy, you have to take a mesh, right? You have to take a mesh. So one end of the mesh will be attached to the sacrum, and the other end of the mesh will be divided into two portions, right? One end of the mesh is going to be attached to the sacrum. The other end is going to be divided into two portions. One portion of the other end of this mesh is going to be attached anterior to the vagina, like here, and the other portion of the other end of the mesh is going to be attached posterior to the vagina, right? Let it be very simple. This is one end of the mesh, this is the other end of the mesh. In the other end of the mesh, I'm going to divide this mesh into two halves. This is one half and this is the other half. One half is going to be anterior to the vagina, the other half is going to be posterior to the vagina. So what is going to happen is this mesh is going to result in fibrosis. So healing is going to happen by fibrosis, and sooner or later this sacrum is going to be attached to the vaginal vault permanently. So by the process of fibrosis, the vagina will be permanently adhered to the sacrum, and this is going to prevent the wall prolapse, right? Good. Now, sacrospinal fixation. So what are the procedures which can be done in order to prevent the wall prolapse is uterosacral suspension and sacrocolpopexy. Clear? But then we also have the other surgery which can be done through the vaginal route, and that is sacrospinal fixation. What is sacrospinal fixation? Let me show you here. Wait. So in uterosacral suspension, I told you that this procedure can be done through per abdominal or through per vaginal route. But sacrocolpopexy, this procedure is actually a difficult procedure to perform, right? So this is one of the difficult procedure to perform, but then it is the best procedure because a mesh is going to be used, and definitely this mesh is going to result in fibrosis, and therefore the sacrum is going to be attached to the vaginal vault in future, right? And this is going to prevent the apical prolapse also, right? So sacrospinal fixation is when sutures are going to be taken, and the sutures are going to be held between the apical portion of the vagina and the sacrospinal ligament. So sacrospinal fixation is similar to uterosacral suspension, where sutures are tied between the apical or the vault portion of the vagina, and in uterosacral suspension that is suspended by the uterosacral ligament. But in sacrospinal fixation, the vault of the vagina is going to be suspended to the sacrospinous ligament by sutures. So one is the apex of vagina. Sutures are going to be taken, and it is going to be suspended to the sacrospinous ligament. So this sacrospinous ligament is going to suspend the apical or the vault portion of the vagina, and this will prevent the vault prolapse. Is that clear? Yes. So with respect to vault prolapse, we discuss about three important procedures, which are uterosacral suspension, uterosacral ligament is suspending the vault of the vagina, sacrospinal fixation, the sacrospinous ligament is suspending the vault or the apex of the vagina, and sacrocolpopexy, where a mesh is used, and this mesh is attached to the sacrum and the other end is attached anterior and posterior to the vagina, and this mesh is going to be healed by fibrosis, and it will permanently adhere between the sacrum and the apex of the vagina, and this will prevent the wall prolapse, right? But then one important thing that you need to consider with respect to vaginal hysterectomy post procedure is not just the procedure to prevent the wall prolapse, but then also you need to prevent enterocele. You may have the doubt that why am I going to prevent this enterocele? So let you see here, right? So this is the uterus and this is the cervix. and this is the vagina. I told you that if you're going to remove the uterus and the cervix, the vaginal stump portion can prolapse. Similarly, if you're going to remove the uterus and the cervix, this portion is going to be absent. So therefore, the portion which is immediately next to the uterus and cervix, the posterior portion, this is the cul-de-sac or the recto-uterine pouch. This is an empty sac, right? So this is an empty sac. What is present in this empty sac? Intestines. Intestines are present in this empty sac, right? So this intestines can herniate out through this empty sac and it can herniate. So in order to prevent enterocele, you have to do a procedure which is called as Mackler-Caldoplasty. What is Mackler-Caldoplasty? Mackler-Caldoplasty. The basic of this procedure is to prevent the enterocele. See, it is very simple. We all know that intestines are present immediately posterior to the posterior vaginal wall as well as immediately next to the uterus posteriorly, right? And this empty portion, this is called as the recto-uterine sac or the cul-de-sac or the pouch of Douglas. So the intestines can actually enter this pouch of Douglas and it can herniate out. Why? Because when the uterus and cervix is going to be absent here, then all the intestines can come inside this cul-de-sac and herniate out. So in order to prevent the post-hysterectomy enterocele, I am going to just obliterate this cul-de-sac. What I'm going to do? I'm going to obliterate this cul-de-sac. I am going to obliterate the path of the cul-de-sac so that the intestines can never herniate down. Let's say, for example, this is the intestines, right? If I'm going to obliterate this path, then the intestines can never herniate beyond this, right? So that is the basic of Mackler-Caldoplasty. So to prevent the enterocele in future, Mackler-Caldoplasty is done where the major procedure is obliteration of the pouch of Douglas is done, which is going to prevent the enterocele. So with respect to hysterectomy, what are the procedures which can be done prophylactically? There are two procedures. One is to prevent the wall prolapse. One is to prevent the enterocele. Right? To prevent the wall prolapse, you can do uterosacral suspension. To prevent the enterocele, you have to do Mackler-Caldoplasty, which is obliteration of the cul-de-sac. So if you are going to obliterate the cul-de-sac, then definitely the intestines can never herniate beyond that obliteration, and therefore enterocele can never happen post hysterectomy. Right? So this is all about the management of uterocervical prolapse in menopausal female. Now I have an important question for you, and that is vaginal hysterectomy, right? Vaginal hysterectomy is the management for uterocervical prolapse. Anterior colporrhaphy is the management for anterior vaginal wall prolapse. Posterior colpoperineorrhaphy is the management for posterior vaginal wall prolapse. See, uterocervical prolapse can be coexisting with either anterior vaginal wall prolapse or posterior vaginal wall prolapse in any female, right? The female might also have uterocervical prolapse along with, let's say for example, cystocele and urethrocoele, or the female might have anterior vaginal wall prolapse with cystocele and rectocele, or the female might have anterior vaginal wall prolapse, right, with uterocervical prolapse. So anything can be existing in a female. So let me say a question you here. A female is coming to you to the OPD and you have done all the evaluation and examinations, and you concluded that this patient is having uterocervical prolapse is there, anterior vaginal wall prolapse, that is cystocele, is there in this patient, and posterior vaginal wall prolapse, that is rectocele, is there in this patient. Now what are the prolapse which is present in this patient? Uterocervical is present, anterior vaginal wall prolapse is present, posterior vaginal wall prolapse is present. So therefore the management is going to be, let's say for example, she is a 53-year-old female. So therefore the management is vaginal hysterectomy plus, for cystocele you are going to do anterior colporrhaphy, plus for posterior vaginal wall prolapse, that is rectocele, the management is posterior colpoperineorrhaphy. Are you going to tell us that you are going to do vaginal hysterectomy with anterior colporrhaphy, with posterior colpoperineorrhaphy? No. It has a term, and that term is nothing but it is called as Ward-Mayo hysterectomy. Ward-Mayo hysterectomy. So if I tell you the term ward Mayo hysterectomy, it means that I'm going to do vaginal hysterectomy along with anterior colporrhaphy, let me repeat it again. See, ward Mayo hysterectomy means that you're going to do vaginal hysterectomy along with anterior colporrhaphy and along with posterior colpoperineorrhaphy. So vaginal hysterectomy with anterior colporrhaphy, posterior colpoperineorrhaphy, all these three together is called as ward Mayo hysterectomy. So if you mention the term ward Mayo hysterectomy, everyone can understand that it is vaginal hysterectomy with anterior colporrhaphy with posterior colpoperineorrhaphy. Is that clear? Yes. So this is all about, you need to learn about the management of prolapse, right? The surgical management of prolapse, both the vaginal prolapse as well as the uterocervical prolapse. If you have any doubt related to the concepts which are taught until now, you can write to me in the Mackler Gmail handle or in the Instagram handle. I will reach out to you as early as been possible. And please don't fail to subscribe